Good evening, everyone, and thank you for joining us tonight for our presentation titled Scleral Lenses, Managing Common Fitting Issues and Complications by Dr. Caitlin Morrison. So I will be your host today. My name is Dr. Ariel Sorenzi. So I'd like to introduce our speaker for tonight. Dr. Morrison started her practice, a specialty lens practice in Scottsdale, Arizona, and she's super passionate about designing specialty contact lenses to restore sight to those that have vision loss secondary to ocular surface conditions. She's a graduate from NECO and completed a cornea and contact lens residency at SUNY. She's a fellow of the American Academy of Optometry, the Scleral Lens Education Society, and is a recipient of the Bert C. and Lydia Corwin Contact Lens Award and the Johnson & Johnson Award for Excellence in Contact Lens Patient Care. And definitely check out her Instagram too. She has so much great content that I learn from all the time. So make sure to add her on Instagram. So thank you so much for joining us tonight.
Hey, thanks so much for having me, Woo University. I am honored to be presenting. I am sorry that John Gellis couldn't be here tonight and I had to fill in for him last minute, but hopefully it'll be a really great presentation and we are going to talk about some very, very similar topics anyways. My financial disclosures is Bausch & Lomb Specialty Vision Products. And today we're going to be talking about what else? Scleral lenses and how to make sure that you get the best fit ever with your patients and that you're able to manage common fitting issues and complications that arise with not only your patients in the clinic, but things that patients may bring up to you as things that they're noticing wearing the lenses. So again, Dr. Morrison, I own a specialty lens practice in Scottsdale, Arizona that I started a couple years ago. It's been an amazing journey and love helping patients with specialty lenses every single day. I know that if you're tuning in, you have probably done some scleral lenses or a ton of scleral lenses, and hopefully both can benefit from this lecture. And you know how amazing it is to fit this population. So scleral lenses, we know the basics of what they're used for. They're used to enhance vision in patients with severe ocular surface disease or even mild to moderate ocular surface disease. I think when I was first starting out and we were fitting scleral lenses, we were thinking of them as more of a last resort. Like if other things didn't work, then we would introduce the scleral lens. I think this was mainly because it was for patients a little bit daunting to have such a large lens. And then for financially, it's a little bit more of an investment upfront for your patients. And that's kind of how I always viewed it. I viewed it as like we were doing GPs for such a long time and they were great. And then we introduced sclerals and they were awesome and everyone loved them so much. But I still used to think in terms of like, okay, soft lenses first, then moving on to different modalities. But the more that I'm in practice and the more that I see different sorts of patients every single day, the more that I realize that finding the best option for your patients is number one. And if that can be solved with a soft lens or something easy, glasses, that's obviously your first thing that you would go to. But introducing scleral lenses early on and just educating your patients about, hey, I think this might be an option for you. Research it a little bit, go to my website, learn a little bit more. If you're interested, contact us. We can always set up a consultation to look at what they would be like on the eyes. And more often than not, I have a lot of patients opting in for the scleral lens. Some of the advanced scleral lenses patients are really likely to go with. And, the basics, keratoconus, corneal scarring, and those corneal transplants, we use those for scleral lenses all the time. We use scleral lenses to fix those issues. But patients who are regular patients, speaking, how many times has one said to you, I just can't wear contacts because my eyes are too dry? Or the other one is, I have a lot of astigmatism, and when I wear contact lenses, they move around a lot. And so, yes, custom softs can be an option, but these are also great patients for sclerals, and introduce them early. Say, you look like you have really severe dry eye. We can do all these treatments, and we will. But another modality is getting you into a scleral lens earlier, and then you can start to heal your ocular surface. So a lot of patients this is very, very popular with are any patients with radial keratotomy. They might be 20, 25, 20, 30 with glasses. These patients got radial keratotomy in the first place because they wanted to be glasses free. So this is a huge population where you can introduce scleral lenses, and they will most likely want to try them out because they didn't want glasses in the first place. And soft lenses generally don't fit them that well. So introduce scleral lenses, they're fabulous, or introduce them early and often. Have your staff educated on what types of patients to introduce them to. And benefits are obviously, number one, vision correction. You can get extremely sharp vision with a scleral lens. One of the things that I always mention to my patients when we're talking about vision is scleral lenses have the potential to give you sharper vision, not only because they're a rigid material, and we know that rigid materials, GPs, hybrid sclerals, do give higher quality of vision because you're getting rid of small amounts of irregular astigmatism. Even if the patient's dry, they probably have a little bit of corneal irregularity, but that these lenses are stable. So on the eye, when you blink, they're going to stay put and they're not going to move around. Sometimes the movement of a lot of those other types of lenses really, really bothers people. And another really great thing about them is that you can introduce large amounts of residual astigmatism onto the front surface of a scleral. And that's very hard to do with other modalities. Hybrids, you can't do it. In GPs, it's a lot more difficult just because of the rotational aspect and the movement of the lenses. But say you have 3 diopters of residual astigmatism, where does that go? What do you do with that? Well, on a scleral lens, it's not only stable, but you can put it into the lens. So these are just things to keep in mind if you're introducing these lenses to your patients and they're asking, doctor, what's the benefit of these? Why should I even try to go through this process? This is really great things to be able to tell them. Dry eye treatment is a great one for patients who have probably tried all the other options. Maybe they've even gone through the IPLs, the lipoflows, and they're like, I've done so much with these lipoflows, etc., but really my eyes are still dry. Introduce it, and then they will love you for it. Protection, if you see anybody with exposure keratopathy from, say, a blepharoplasty that was a little too tight and they can't close their lids all the way, more common than you'd think, or a 7th nerve palsy, even a small one where they still can't close their eyes completely, a scleral lens might provide them the opportunity to heal that cornea better than just wearing a soft bandage contact lens or aggressive all day long lubrication, and might provide patients another way to live their lives without having to constantly put drops in their eyes, which is, when you think about it, if you're doing a drop every hour, that's a lot of your life that you're thinking about putting in drops. So another thing you can do with scleral lenses is temporary healing of corneal issues. And mainly when I'm saying this, it's mostly patients who have non-healing epithelial defects. So maybe they just they have neurotrophic keratitis and they really can't heal, and they're like, they have this open wound, they're using antibiotics, you're putting a bandage soft lens on them. This is a great option for them to heal it maybe a little bit more quickly, and you can use them in some cases with scleral lens sleeping overnight to try and heal the corneal, the non-healing epithelial defect. And once it's healed up, then you can remove it as long as you're seeing them every day very regularly. So really cool things that you can do that you might have already known, but things to think about for future. And with such an amazing technology and such a complicated and complex technology comes different complications than we've dealt with in the prior RGP hybrid space. There's a lot of complications that arise with lenses. When I go out and teach other doctors how to fit scleral lenses, the same issues come up again and again and again. And they're only issues because it's very common with all of our patients. You can be a great scleral lens fitter and you're still going to see somewhat of the same complications that you did when you were just a novice. You just know how to deal with them a little bit better. So this list is just a couple that I thought of, but the main ones we're going to be discussing today are lens dropping, lens fogging, so midday fogging, that annoyance that everyone, like a lot of people get, and conjunctival redness, which is, I threw it in there. It's not as common, but I'm going to show you some very specific things that you will probably see in practice and how to get rid of them swiftly and right away so that you never have to see them again. The other ones on this list, if you had a specific question about potentially a patient of yours, or like what happens when I get graft edema, those things I can all answer at the end. Pretty much dealt with everything. Conjunctival chalasis, usually like a don't worry about it type of situation, but ask at the end if you have a specific question. I'm happy to go through it with you. So I started out with this subcategory because lens dropping is probably the most common issue and thing that you will see in clinic, and it manifests with a lot of other different symptoms. So lens dropping is when, if you see this picture of the lens on the eye, the patient may, I mean, they have bubbles under the lens, but disregard that. They may see really clearly and be like, wow, this is really great. But you're looking at the fit of the lens, and there, clearance-wise, there's a lot of clearance inferiorly, and then superiorly, and particularly superior nasally, the clearance is getting really, really thin. Like it's almost touching that superior limbus. It might even be touching the superior limbus. And you're like, okay, well, my original thought years ago was just, I'll just increase the limbal clearance and then that'll be fine. But you increase the limbal clearance and the lens keeps touching superiorly. And you're like, why is this happening? I've increased it so much. Like, how do I get this lens off of the limbus? Because we can't have that long term. And the real issue isn't so much that the limbal clearance in one area is different than another. It's the fact that the whole lens has decentered. And with that decentration, you just get a lot of other issues. One of the issues that you will have when a lens drops is this, and I took this, I guess, from Stephanie's website. And this is a picture of a lens that has dropped on the eye. And inferiorly, you can see that at the very perimeter of the lens, there is whitening, so blanching. We all learned about blanching means that the lens is too tight in that one area. But you can also see that right above that blanching is the conjunctiva looks like it is like thicker and redder. And it looks like it's being sucked up under the lens. And you can actually kind of see, and this just goes to my point in a minute, nasally, if you look to, I think this is the right eye. So if you look to the right of the screen, you can kind of see a shadow at the very edge of the lens where you think, oh, that edge might be too loose. But then I look at the bottom and that looks too tight. So do I loosen up the bottom and then steepen up the right side of the lens, or what do I do? This lens is definitely dropping. And one of the best thing that you can do when this happens is you'll see very little, again, to review, very little clearance superiorly, a lot of clearance inferiorly, medium in the center, and then the edges will be, either a little bit or a lot of clearance, probably moderate. But you see this and you're like, huh, what I would do is I would paint Fluorescein over the top of the lens so then you can see the edge profile, and then get right back in the slit lamp, use your finger and then press the lens or the lid up with the lens and press the lens so it's more in a central position. So instead of the lens being here sagging and then you have all this weight down here and you have no clearance up here, push it up into position. Like if it were centered, what would it look like? And I bet you're going to see a couple things. I bet you're going to see too much central clearance so that the lens increases in weight. And you're probably going to see that that fluorescein that you painted on the front of the lens, you can actually really easily push it up inferiorly under the lens. So now once you have it into position, the inferior portion of the lens actually looks a lot flatter, and it looks too flat. And you're like, whoa, that's weird, because when I had it in the dropped position, it looked too steep because it had all this impingement. But that's really from the weight. All the weight of the lens is now inferior, and it's just bearing down on that cornea or on that sclera so harshly. And it's bearing so hard and has so much clearance that the conjunctiva is actually being sucked up under the lens and becoming edematous. And so what you do is you push up the lens, you see that there's fluorescein under the lens, and you say, okay, actually, what I'm going to do is I'm going to decrease the central clearance to decrease the overall weight, and I'm going to actually steepen up the inferior and superior edges. And then that will in turn push the lens up into a more centralized position. But if you're just looking at this, you would think, why would I steepen the inferior edge? That seems crazy because it looks like it's impinging, but it's really not. And this matters because the lens dropping matters if there are complications. So, for example, I have a patient and I fit him years ago in a conventional scleral lens. He has an extremely toric sclera. So we have him in the steepest edge possible in one direction and the flattest edge possible in the other direction. And so he just really, it took a while to get him to a position where he was really happy. And every year I see him, and every year, he's like, oh, this lens feels so great. And then maybe he has a little prescription change. So this year he had a prescription change, and I was looking at the lens again, and I was like, I don't think that I did as good a job as I could have done if I had known everything that I know now then. So me being very type A, I was like, what do I do? Do I fix the entire lens and make it look more perfect looking? Or do I just add his prescription in, which is what he really needs, and then he will be happy again, and then we can move on with our lives? And it was really hard for me to not change the entire fit of the lens. But I said to myself, this, and his lens was dropping a little bit, and I definitely decreased the central clearance just a little bit, maybe like 75 microns or so. But overall, I just added the prescription back into the lens because his cornea had been healthy for years. The sclera was really healthy and white and quiet. He was happy, and he just needed a prescription change, and he was ecstatic when we gave it to him. And then now he's on to the next year. So it's really only a problem, anything in scleral lens fitting or lens fitting in general, it's only a problem if the patient has poor vision, or their health of the eye is compromised, or they're uncomfortable. So if you are having a patient that's comfortable, try not to chase your tail too much. If they're loving life and their cornea is healthy and their vision is really good, it's okay to just say that this is a really good lens and just move on. We all try to chase perfection, and sometimes that's a little difficult. But it is a problem if you have issues that come up because of it. So superior nasally, the lens is always going to be a little bit closer. I say always because it's just like 90% of my patients that I fit, the first initial lens, you're like, okay, it's a little bit closer over there. And then you go and look at it and it's fine. And you can see on this picture to the left, this shows the lenses decentering inferior temporally, and then that would make it closer superior nasally in terms of clearances. And maybe this person is getting a lot of discomfort and redness inferiorly around the conjunctiva. And poor alignment with the sclera results in greater fogging. And so patients with a poor alignment, a lens dropping, they actually do get this fogging quite a bit, because fogging of the lens and the fogging of the vision while you're wearing the lens does have a lot to do with how well the edges of the scleral lens are aligned with your sclera. And we'll talk about that in my exact way that I go about doing that in just a moment. But so why does this lens decentration even happen? It happens because you have muscles on the sides of your eyes, and they pull the sclera at different intensities. So generally speaking, nasally, or the area where the medial rectus would be, it doesn't pull as much, and so you have a flatter sclera. And then superior inferiorly, it pulls more, so you're going to have a steeper sclera. So generally speaking, superior and inferiorly, you're going to need a steeper edge to your lens, and nasally and temporally, you can have a flatter edges to your lens. Again, I'm not, I don't know the exact distances at which it pulls, but I have a profilometry in my office, and I think the study done was like 67% of patients or 76% of patients, mixing that up, actually have a completely irregular sclera. So they have different elevations in different areas, period. And I would say that in my clinic, I'm using toric peripheral curves of the lens, of scleral lenses, for 95% of my patients, just because they end up fitting better and centering better, and it just looks better on the eye. The picture to the left really demonstrates that this lens to the left has too much clearance. So if that lens looks like it's about maybe 250 microns thick, 250, 300 microns thick, and then you can compare that lens to the band of green, and the band of green is probably like 500 to 600 microns. That's a lot of fluid. You can see though, this is actually like a decently centered lens. Superiorly and inferiorly, you have about the same clearances as you do. You don't have a very small amount of clearance in the superior area and a large amount in the inferior area. However, just reducing this overall clearance, the central clearance, will help you take down the overall weight of that lens so it drops less. So you can see on the right-hand side, that was a patient of mine, and you can see that the band of green all the way across their cornea is, that's the tear film layer. That looks really even. And so probably just got lucky with this one. It looked really perfect. And your fits are not always going to look this perfect. But again, if you try your best for those idealized clearances. So ideally after settling, you'd have 175 to 200 microns centrally. You would have 125 to 150 mid-peripherally, and you'll have like 75 to 100 limbally. People vary in how much they do. Some practitioners do prefer less, but as long as you're in that ballpark, you should be good. And if it doesn't look perfect, that's okay, as long as the patient's happy. And then number one way to decrease lens dropping and increase the centration of the lens for a better fit and avoid all those other issues is decrease the central clearance, push up the lens, see what the central clearance really is, and then decrease it that way. And you can look at the mid-peripheral and limbal clearances as well. I tend to never almost increase limbal clearances. It's just a thing I have. I feel like if you can center the lens really well and you can center the lens well, the central clearance is great, the mid-periphery is really good, then the limbal curves will kind of figure themselves out. Most of the time this happens for me. And you can see the red is pointing to the lack of clearance, the white is pointing to the too much clearance, so this lens is dropping. If you decrease it and you align the edges, you can get a better fitting lens like the one on the right, where it's a very equal and even tear film. And this is a patient of mine who came in because they had been struck by a tree branch in the eye, lots of light sensitivity, big corneal scar. You can see on the right, you can kind of see some brownish pigment inside the scar still. I think they still had some vegetative matter in there, which was interesting. And so this is exactly how I designed this lens for this patient. So what I do is I take a piece of paper, or now I have, it's a electronic piece of paper, essentially. It's called The Remarkable. I'm not sponsored by them. I wish I were, because I tell people about it all the time, but I like drawing things out. So I draw out the fit of the lens. I label all of the clearances, because I think it's really hard to assess that when you just type it on the EMR. And then I write notes to myself. You can see all the way around the lens. I've put, 1+ impingement. I put a little bit of a heel toe kind of edge. I mark the clearances, and then I put on the bottom what I would decrease it by, what I would increase it by, what I would do. And so this is the design of this lens that I did for this patient. If you see the red circle, so this, and I actually highlighted where the toric meridians were on the, and again, we're talking about the periphery of the scleral lens. So the peripheral curves of the scleral lens are now toric. So I fit only now with toric fitting sets. So if you have the option to trade in maybe your scleral lens fitting set that has a spherical peripheral curvature, if you can trade that in with your manufacturer for a toric set, and they usually have ones that they'll send you that start out about like 120 or so microns difference between the two meridians, that is going to save your life. It's going to save you so much time. It's where you're going to end up anyways. So it's better to see it on the eye, especially if you have anterior surface astigmatism. So first thing I would do, if you don't have it already when you end this lecture, is get into contact with your manufacturer and ask them about upgrading your set to a toric one. It's going to be the best thing you've done if you don't have it already. So see the red circle right here in this meridian, and you can see I did the profilometry on this on this patient. They have you can see these little numbers here. It's 38 degrees and 36 degrees, and this was opposite of each other. And then on the other meridian, you can see at the edges I have 45 degrees and 46 degrees, and this is the scleral. This is the elevation of the sclera. And so 45 is a steeper sclera, 38 is a flatter sclera. So the flat meridian went right to that flat scleral meridian, the flat lens meridian, and they lined up. And then the steep was on the other opposite direction. But if you don't have a profilometry, it's fine. Just put a lens with toric peripheral curves on the eye and see where it ends up. So this person, for the red, I put 1+ impingement, because this flat edge was impinging on both the superior nasal and inferior temporal areas. And then, oh, this is the left eye. So superior temporal and inferior nasal. And then on the green circle on the left, you can see that that is the steep meridian. On this particular lens, we're using a minus, it was set up to be a -4, and this was like the lens that you put on the eye first. It was a -4, which means that it's 4 steps steeper than standard. And usually that goes in steps of about 25 microns to 30 microns per step. That's generally speaking what most manufacturers will do. So if you're like, oh, what does this even mean? If you start out at 0 and you have a +1, 2, and then a -1, 2, standard is whatever standard that may be for you. To make it flatter, you would just go flatter 1, 2, or steeper, steeper 1, 2. So this had flatter by 3 steps, or 3 times 30 is 90 microns. So about 90 microns flatter. And then the -4 is about 30 times 4, so like 120 microns steeper. So these meridians were opposite of each other. So what I did though was the flat one was impinging, so I had to make it flatter. And so if you follow the arrow to the other side, this is what I ordered. I ordered a +5, so I flattened it by about 60 microns. This was years ago when I fit this patient. I probably would be a little bit more aggressive now. I do grade my impingement, so I do put trace to 4+. That way, if I'm ever going back and ordering a lens, I can be like, okay, did I want to do a 60 to 90 micron change, or do I want to do just like a small one, a big one? What do I want? And if you follow the green, let's go back a second. If you follow the green arrow, you can see that I put that this was steep, but I also wrote to myself almost too flat. And it has a little bit of a heel. So when the edge lands, it's like this, it kind of comes up a bit. So I wanted to steepen that edge. So I went from a -4 to a -5, and I only steepened it by 30 microns. I probably wouldn't do that Now I probably would have gone a little bit more aggressive, but you get the point, and this patient was happy. So what's the meaningful change to peripheral curvature? So how much do you change by? If you see trace impingement, if you see 4+ impingement, if you see an edge that's too flat and the fluorescein seeping under the lens, what do you do and how much do you change by? So generally speaking, meaningful change is anywhere from 50 to 90 microns of change. And meaningful just means like if you change it, it's actually going to make a difference. I would err on the side of being a little bit more aggressive, especially if the lens that you put on right away looks like crummy to begin with. Just change things at a greater rate. It will save you time in the end instead of going little by little by little. You can always change back because then you'll know your limitations. It would be the best thing for you if you're working with a particular set. And ABB can probably speak to this because they have a lot of different sets, but it would be beneficial to ask the consultants, like, what do you consider meaningful change? I work with one lab that considers meaningful change 50 microns. I work with another lab that considers it to be 90 microns. And so when I'm designing those lenses, I do think about that. And another way, if you, again, you don't have profilometry, a lot of people don't have that, and it's totally fine, and you can still fit amazing lenses, but using this fluorescein over the top of the lens once you have it on is like the best thing that you can do, and something that when I was first starting out, I did it like sometimes, but now I do it for every patient at every lens follow-up because I want to stop problems before they start. If the edge is really flat and the patient's having a lot of fluorescein gush under the lens right away, even if they're comfortable, even if there's no impingement and there's no lift that I can see, and the lens isn't moving too much, that person's going to have fogging. So like, why wait for it to happen? So what I do is I put the fluorescein, once the lens is on the eye, in the superior conjunctival area, and then I let it drip down over the eye for like a second. I put them back in the slit lamp. I look in the slit lamp and I look at the entirety of the lens. Is the fluorescein seeping in from any direction? I usually use a diffuse blue light, which then I then switch to a diffuse white light because it's good to see in both ways. And if you see it seeping under right away, you're going to know you need to steepen that edge because that edge is too flat. That's letting in a lot of fluorescein. You're going to have a fogging issue. And also the patient is probably going to feel the edge of the lens, whether they're like super perceptive to it or not. Some really sensitive patients will be like, oh, I feel it. And you're like, okay, just let the lens settle for a bit. But if after a couple days, they're still like, oh, I'm very aware of the edge, it's probably too flat. And you can just do the fluorescein and see where it is. And it's probably right where they're telling you. And then you can make an adjustment. And the right one is very easy to see, impingement. Probably the hardest thing to do in scleral lens fitting is what edges, what's an edge profile that is ideal, because a lot of times we look and they look fine. They're not impinging, they're not lifting off. A lot of times you have to go on patients and what they're telling you. If they feel a scratchiness, it's probably too loose. If they're comfortable at first, but then over time they feel like, I can feel the lens edge. I can feel it, but you have no fluorescein seepage. It's not a scratchy feeling. It's probably too tight and you don't even know it because there's no impingement. So that's just a tip that I've learned over the years that's been super helpful, is listening to the patient's complaints and being very specific about when do they feel it is really great. I'm going to quickly go through this. This is just using some technology in order to help you with your fits. If you see the bottom right picture, the purple is a steep edge or a steep sclera. The red is a flat sclera. So you can see this person has very toric sclera. And this person is a radial keratotomy patient, but like they had one of the most toric scleras I've ever seen a person have. I think I ended up with them like a flat 10 and a steep 10, which is like you know, 300 microns flatter and then 300 microns steeper than standard. So the patient's very happy, and they had a lot of impingement. You could obviously see it. But this was interesting, and if you have this type of technology, or you're thinking like, what's the difference between toric and quadrant specific? And in quadrant specific, meaning that in the haptics or the peripheral curves of the lens, nasally, inferiorly, superiorly, and temporally, do I make them all different elevations? I would say if you can stick to toric, just stick to toric. It's so much easier. It's an easier rotation to account for if you have anterior surface toricity. If you have a quadrant specific lens, it's fine. And if you're doing them and you're having a lot of success, great. If you end up with a patient with 3 diopters of SIL on the front of the lens, and then you switch one of those edges, just one, it could throw off the lens and you have to do the prescription over again. That's just been my experience. So I've actually switched from doing quadrant specific to toric, mostly, a lot more. And other technologies that you can use for this are scan-based lenses, where you take a scan using the profilometry and make a lens out of that, which you can see kind of incorporates those lumps and bumps. And then mold-based scleral lenses, which is the eye print. And then this is a patient that had a really ectatic graft, not the patient to the right, but this one. Oops. There we go. This patient on the left, and this was probably the deepest lens I've ever designed, and it was really cool, and he's still happy and looks really good. All right, so we talked about lens dropping, which if you can solve the lens positioning and make it become more centralized by decreasing the central clearance and aligning the peripheral curves, you will decrease a lot of these other issues. That is like your first go-to, is getting the lens to center as well as possible. But a lot of patients are having fogging. And what I'm going to be discussing particularly here is midday fogging, which is posterior lens tear film fogging. If you can see this picture on the right, under this lens, there's just a lot of debris. And a lot of patients right now, especially in Arizona, if you can hear me sniffling, people are having a lot of allergies. And so we're also getting anterior lens fogging, which is deposition of, allergic type materials on the front surface of the lens, which is probably more annoying than the posterior surface, because there's not as much as you can do, but I have some suggestions. If you are interested, just ask me the question later, because there's a whole thing that I'd go through. But the posterior lens tear film fogging is probably the most common thing that you'll come across. The patient says, "Doctor, when I put on the lenses, they're so clear and I love my vision, but after about maybe 1 hour, maybe 5 or 6 hours, then my vision becomes a little bit foggy." And I always ask them to quantify this. So is it after 30 minutes? Is it after an hour? Is it after 6 hours? Is it after 12 hours? If you're getting a little bit of fogging after 12 hours, I feel like that lens is a success, and I really don't care that much about it. But if you're getting fogging after an hour, that's an issue, because you're probably going to have to take the lens out midday and clean it and then reinsert it. So ask them to quantify it for you. How much of an issue is it? If you're looking at the patient in the slit lamp and they've had the lenses on for an hour or two, and when they blink, the lens is still moving, it's too flat. The edges are too flat. And then if you just steepen them, you'll solve a lot of this fogging issue. But what is fogging? Like, where does it even come from? So studies show that it's mainly neutrophils, so some leukocytes, lipids, proteins, and I believe a lot of it is also cell fragments like epithelium. The epithelium sloughs off during the day. And the reason why I think this has even more of a component than maybe some other things in the tear film is because I see a lot more fogging in patients with radial keratotomy, dry eye, and allergies, particularly dry eye and radial keratotomy. If you think about the front surface of an eye who has gone through radial keratotomy, you have an eye that is so irregular because of the slits, that every time they blink over the lens, it's just those epithelial cells have got to be sloughing off more frequently. That's just a theory of mine, but I do see fogging more in patients with all of these three conditions. One of the things to do for these patients is if you see a patient with severe dryness, um, especially like a Sjogren's syndrome, a graft versus host, um, a Stevens-Johnson syndrome, if you see a radial keratotomy patient, if you see even like maybe a corneal transplant patient where it's very irregular, alert this patient right away that they will probably have at some point in the day a little bit of fogging, to expect it, and that you will try to get rid of as much of it as possible, but setting expectations for those patients is very crucial because they will probably have fogging. If they know about it beforehand, it won't be as much of an issue. And fogging, why does it happen? It can happen because you have too much clearance, particularly limbal clearance under the lens. The lens edges are too tight, the lens edges are too loose. More likely the case, but can be either. Overall, the edges are not aligned, or you have an ocular surface disease, like I had mentioned. So if the lens is too tight or too loose, what would that really do? So too tight allows too much fluid to come up. Too loose allows for too much fluid to come up under the lens. And anytime you blink and you have maybe some crummy tears, they're just going to get up under the lens really easily. So those edges should be tightened. Again, you can do that with the fluorescein over the lens, seeing where it's seeping in, especially once the lens is settled down. But if the lens is too tight, you're also rubbing on the conjunctiva, on the mucus or mucus creating goblet cells. And so you could just be aggravating the eye all day, and it could be creating more mucus. And then that mucus could be getting up under the lens. And so how do we fix it? Number one, I've said this like a million times, align those scleral lens haptics. Ask your consultants as many questions as you can about like, how do I get the best fitting haptics? But the best thing that I could recommend is get a fitting set that already has them in there, fluorescein over the lens, and go off of the patient's experience. Can you feel the lens? If you can feel it's too loose, the edge is too lifted. And let them settle for a minute, especially when they first put it on. And then is it too tight? A lot of times when you see it, you won't see it being too tight. That's the nuances of scleral lenses nowadays. We become such good fitters that sometimes the lens is actually too tight and you don't know because there's no impingement like you learn in school or lots of these lectures. It's not obvious. And even when you take an OCT of the edge, sometimes it's not obvious. And so go off of the patient and like, I can feel the edge and you see nothing going on, no fluorescein, no anything. It's probably too tight, and loosen it. And I think you'll be a lot happier. Decrease the central clearance and particularly the limbal clearances. Try to get to those clearances where, the ideal clearances, or get as close as you can without touching. But I do err on the side of 75 microns is like my absolute limit. Like I really don't like it to get any closer than that. And that's just a personal preference because I want to give my patients longevity. Say their transplant changes in like a month. I don't want them to touch the back of the lens and have to be refit. So, and then treat underlying surface issues. When you have a consultation with the patient and you fit them in lenses and you say, okay, I'm going to order your lenses. You're going to come back in like 3 to 4 weeks, right? For the dispensing. Give them all of the treatment now. So start them on any drops, any warm compresses, omega-3s, like whatever your dry eye routine is, start them off right away so that when they come back, their eyes are ready to go. They are beautiful and you don't have any issues. And then some patients with fogging and very severe ocular surface disease really do better with a higher quality filling solution like Neutrophil. And again, like I was mentioning, I want to minimize the amount of times the patient's in my chair because my patients are busy. I'm busy. You guys are all really busy in your practices. If you can eliminate something and not wait for it to be a problem, just do it right off the bat. So we know that extremely dry eye LASIK, any types of those autoimmune conditions, and radial keratotomy, those are generally going to be more of a fogging issue. Radial keratotomy, yes or no, but if they have a dry eye, just recommend Neutrophil right off the bat. It's going to be so much easier for them. And then if they choose to use one of the other solutions, that's totally fine as well. But you can do that. And then the higher viscosity is putting a couple drops of the Refresh Celluvisc preservative-free in the bottom of the scleral lens, filling it up with saline solution, popping it on the eye. I found that over the years, I really like a Refresh Relieva, preservative-free, of course. That's a really great one that I think works a little bit better than Celluvisc. Again, no financial disclosures, but that works really well for my patients. And you probably have ones that you're very partial to, so use those preservative-free tiers. Line scleral haptics, decreased central clearance, dry eye protocol. If you want to start them on a medicated eye drop, Cequa, Xiidra, whatever it may be, start them right away so that they have time to let the drop really actually work before you introduce a lens. Patient expectations, so telling these patients they're going to get fogging. And then again, these are my favorite solutions. And the last thing that I'll talk about is conjunctival redness, which again, remember I said that it wasn't very obvious for a tight edge. Most times it is not obvious and your lenses look great, but sometimes it's very obvious. And when these things occur, if it's not just a generalized, you need to make the lens flatter, which you'll already be doing, sometimes it's a little more insidious and you're like, why is this person getting so much redness? Like, what is happening? And you can see this because you get these impingement of the blood vessels and they're really irritated. And so this first patient, obviously you need to flatten the edge of their lens. I would also see what the clearances are, decrease the clearance a lot. I just had a patient who I put scleral lenses on for the first time. He had really tight fitting GPs for a long time and he wasn't able to get out of them because he has keratoconus. It's pretty severe. And so I told him, like, during this fitting process, your cornea is going to change. And so when he came back to me, he's like, I love these lenses. They're so great. The scleral lenses, like, my vision's so good. They're so comfortable. His eyes were beet red. And this is so rare. And I was like, man, your eyes do not look good. I don't like this at all. And what I think happened was when I originally did the estimations of clearances, I thought that his eyeball was going to bounce back and be steeper because the RGP was crushing the cornea. So when it bounced back, it would come out. I don't know what happened, but this guy had like 500 microns of clearance all the way around his scleral lenses, and it was kind of crashing down into the conjunctiva because it was so much clearance. And so, yeah, we're going to just take down the clearances and fix that. And I think his eye changed between then and now, but sometimes it's very obvious. And so look at the clearances first, number one. This is an interesting patient that I had who had radial keratotomy, wearing a Scanbased lens, and I could not get rid of this like irritation of the conjunctiva, redness. And again, this patient was very happy. And I was like, no, this isn't, you're happy, but I'm also not happy with the fit of this. And so we're going to do some things to make it better. And you could tell this eye is just irritated. But if you look at it, like, it's not, you look at the edge, like, there's not impingement there. It's not super obvious. And this is his OCT image, the left one. That's the one when the eye was super red, which is so bizarre. Because this was when I first put it on, the first time the lens ever went on. So the conjunctiva isn't irritated yet. So this is the lens edge. It's really thin and really skinny. And I think it was irritating him. And that's the only thing I could think of because it's aligned. There's no impingement. When I take it off, there's no conjunctival staining. It was so bizarre. And so I just asked the lab to make the edge of the lens a lot thicker. Some labs can, some labs cannot, and to make it rounder so it didn't irritate him as much. And so what I pointed to, that's irritation. He came in wearing his lenses. They were so irritated, the eye at this point, that's like the swelling on the conjunctiva. So I put him in this lens, and that's his eye now on the left-hand side. You can compare that to the eyeball on the right-hand side, which is so much more irritated. So I was very happy with these results. And this is another very interesting case that I had where clearances were perfect, lens was perfectly aligned. There was No impingement. It might look like it on this picture because her eye is so irritated, because she has radial keratotomy. Radial keratotomy is one of those types of eyes where you'll see conjunctival redness more often. And the reason I think that happens, and this is just me making up a theory of my own, is because the lens design, because of the eye, is a lot flatter centrally and then steeper in the mid periphery, because that's what the eye looks like, right? But that probably, if you're wearing a scleral lens, creates a suction force that drags up the conjunctiva into that space where there's more, where it's steeper. And so you get this conjunctival redness more often, and you get more conjunctival chalasis, which again, conjunctival chalasis, don't worry about it unless it becomes like this woman's, where hers was like sucking back up and becoming very uncomfortable. And she was in pain, and I felt bad for her because I'd given her her lenses right before my maternity leave, which I only took off a month. And she called me, she was on vacation. She's like, yeah, my lenses aren't feeling very good. And I was like, I didn't sound dire. So I was like, why don't you wait a couple weeks? I'm going to be back. Just come in when you can. She came in like this, and I was like, wow, I'm so sorry. I should have just come in and seen you, or had someone come in and see you. But so she had a lot of suction forces, and I did everything: loosen the edges. I decreased the clearances. I made sure it aligned really well. I mean, this was really tough. And you can see all the things that I did there. You can increase the diameter too, which makes it maybe it'll land smoother if you increase the diameter. So we did all of these things with her. The only thing that worked for her is that I put fenestrations in the edge of the lens. With some labs, you can do this. Again, with some labs, you cannot. So you have to ask your manufacturer what you can do. But this is really only an issue if it becomes an issue. And you can see, so before fenestrations, left eye. And then after fenestrations, I also made the lens a little bit bigger, but I really don't think that's what did it. It's not that much bigger. It's like maybe 0.25 or something, 0.25 millimeters bigger. But look at that right eye. It is so much better, so much more quiet. This was huge. And you may be wondering, where did I put the fenestration? So they go in the landing zone. They don't go in the middle of the lens. There's no induced bubble like you do with eyes that are in need of oxygen. So she shouldn't have a bubble in front of her face, but you put it right at the edge of the lens. And sometimes labs do one, sometimes they do two, but it's right in that landing zone. So right where the edge lands, they put a little hole right here, and it just decreases the suction. And so now that I know this, if I see a patient who's having a lot of suction issues and it doesn't look like it's a tightness issue per se, I'll just do fenestrations right off the bat. If I do a specialized lens that can do the fenestrations, and I have a patient with radial keratotomy, do it right off the bat. First lens ordered, fenestrations already, because I know that this is a problem more often with these patients. And again, I want to reduce that chair time. So making everything almost exactly where I would want to be at the first lens order, and knowing these things going in, is very helpful. So I hope some of that was interesting. Hopefully I did Dr. Gellis some justice. Here are a couple of my citations, and then let's go to some questions.
All right. Thank you for that presentation. That was amazing.